Guidelines do support local therapy. National cancer guidelines say that local therapy should be considered for limited metastatic disease or people with a few spots of cancer who are otherwise doing well. It's also indicated in the setting of non-small cell lung cancer for people with limited progression while on medication, and then also for symptom relief and prevention of symptoms in high-risk areas such as around the windpipe or around the spinal cord. A lot of times we don't feel super comfortable to watch those. And so a multidisciplinary approach is recommended. Now, on the next slide, there's going to be a lot of clinical trials that are ongoing. So I just want to preface with that. It's probably the most dense slide of this presentation, but I do think it talks about a lot of important studies going on. And so 2 to 3% of global oncology research spend is spent on primary radiation oncology questions. So a lot of these are collaborative group studies, but it's really fantastic that this work is being done. So Sabre Comet 10 is for people with up to 10 sites. Remember how I was saying earlier, it's not just about counting on one hand. This is led by David Palma, and the early results will be reported next year. These are for folks that have a treated primary tumor, but also it includes all types of histologies. Now, there are some here that are specific to lung cancer, but these are the Sabre Comet trial is like a landmark study, and these are the follow-up studies, and most of these are phase 3. I'm very excited about these results, and we'll have to see, right? Several key questions remain, but this allowed up to 10 sites, and it will be reported next year. I think Sabre Comet 3 will be reported in the next 2 to 3 years. It opened up after 10. Now, Sabre Sync is really interesting. It's an intact primary, and so that's for folks that present with a untreated spot in the lung and metastases. And interestingly, rinse and repeat radiation is allowed, forever essentially, to help folks stay on the same medicines. And speaking of which, CURB-2 is a study about when spots show up later on. Do we switch the medicine or do we treat the spots that pop up? So that's an interesting study. And lastly, I just want to call our attention to ARREST-2. That is for polymetastatic patients that don't really have any other medicine options, and they want to have a break from standard medicine or no further lines of therapy. And they use stereotactic radiation to over 90% of targets. It's wild. I've seen the plans for these. But that's, I think, one of the new frontiers where we might be changing from number of disease sites or number of spots to treatable disease burden. Now it uses a little lower dose, but anyway, I just wanted to mention that, and several questions remain. So at the end of the day, local therapy can reduce pain, prevent problems at high-risk sites. It can delay switching to tougher or less effective medicines, and it can improve or preserve quality of life. And it occasionally can give long-term remission in very select cases. The take-home points is that radiotherapy is precise and safe. It helps control cancer in targeted areas, and it often extends how long a medication may work. It's usually completed in just a few treatments, and we'll make decisions together based on your goals and values. And so that's it for me. Sorry, I think I went a little bit over, but thank you so much for your time.